Good morning, everyone. And the topic given to me today is recurrent diseases after pediatric transplant. And we'll start with a case scenario because this was the only case in which we had a recurrence of a disease, primary disease after transplant. So he was a 17-year-old boy who had a disease onset since 12 years of age. He had a decompensation and underwent transplant at 14 years of age in 2016 at ILBS. He was diagnosed as a case of PSC, had decompensation, growth failure. Indications included recurrent cholangitis, high MELD, and underwent transplant in 2016 at 14 years of age at ILBS. Mother was a donor. It was a duct-to-duct anastomosis. Post-operative period was otherwise uneventful. He was discharged on post-POD 25 on triple immunosuppression. But he had a very stormy course starting about roughly 9 months post-transplant, in which we had recurrent episodes of acute cellular rejection. Even we can see, we can see in May 2017, then July, even in March 2018, continued to have recurrent episodes of acute cellular rejection, which used to respond to increased immunosuppression requiring pulse therapies. Biopsy showed typical acute rejections. He had a very typical erratic follow-up. He was a resident of Maharashtra. In 2019, things worsened. At this time, he developed jaundice also. GST again went up high. At this stage, also developed diabetes. And this stage, biopsy did not show evidence of acute cellular rejection, but started showing evidence of biliary pathology in the form of mild ductal reaction, including periportal fibrosis. Things worsened. He used to come for a follow-up and then used to disappear for a few months. And in 2020, he had a frank decompensation of the liver disease, developed jaundice, pruritus, and ascites, had cholangitis, required ERCP stenting, and developed de novo IBD post-operatively. He had no pre-LT IBD that was evaluated. Flares, mesocol was added, developed jaundice as high as 24, frankly decompensation liver disease, developed AKI, and he was continued on supportive management, then was again lost to follow-up, and he expired almost 4.5 years post-transplant. And at that time, ANCA came out to be positive. So when we did a MRCP, there was a mild anastomotic stricture with intra-IHBRD, and the biopsy had shown portal expansion with periductal concentric fibrosis, developed severe cholestasis, bile plugs, cholestatic pseudorosettes, but there was no evidence of any classical evidence of late acute or chronic rejection or acute rejection when the last biopsy was done. So we kept a differential diagnosis. First possibility was obviously chronic rejection because he has recurrent episodes of acute rejection in the previously. Had recurrence of primary disease, that is PSC, was also kept. Biliary anastomotic stricture and drug-induced injury less likely. So when we tried to dissect this case, most commonly what we thought of was recurrence of primary disease because he had, it is common, the onset was roughly around 3.5 to 4 years of age. Biopsy had shown classical periductal fibrosis. There was duct damage and ductular reaction. The close differential diagnosis of a recurrence of primary disease, that is PSC, is chronic rejection, especially if there is a history of recurrent acute rejections or late acute rejection with poor compliance. But typically, a biopsy of chronic rejection does not usually show ductular reaction. There is no periductal fibrosis. And there was no other evidence of arteriopathy or portal inflammation or any zone 3 changes which could suggest chronic rejection. And one of the other differential diagnoses was biliary anastomotic stricture. So what all diseases can actually recur after pediatric transplant? If you look at the large series, the most common etiology of pediatric transplant is cholestatic disorders, that is biliary atresia. Metabolic come about 20%, tumors, ALF constitute about roughly around 10% each. This is the split database from United States, 2,000 patients. If you look at Indian studies, most commonly etiology is still biliary atresia, constituting about 75% of all pediatric liver transplants. ILBS data, including yesterday night's patient, we had done about 127 patients as of now. Major groups include biliary atresia and ALF as expected. In this case, other than this case which I just presented, this is the only case in which we have documented a recurrence of primary disease as of now. So what all diseases can recur after transplant? Infections may be there, but it is very less common in pediatric population. You can look at immune diseases, autoimmune liver disease like autoimmune hepatitis and PSC in children. You may have malignancy like hepatoblastoma and SCC, and multi-system disorder. What I'll focus more is, because the data in pediatric liver transplant on recurrence is primarily in immune diseases and some metabolic and genetic disorders like PFIC2 as a special population. So I'll be focusing more on these two entities. So recurrent autoimmune liver disease, if you look at this slide, I've just tried to compile all the series on pediatric PSC, recurrence of pediatric PSC after transplant. Except this study from Milo et al. When he was working in Houston, Texas, all the studies are retrospective in nature. The overall incidence varies from 10 to 50% incidence, and time to recurrence is usually after 2 years of age. Roughly the lowest age is roughly around 19 months. So you can always say that between 2 to 5 years of age, that is the onset from time from LD to the recurrence. And age is usually higher in these cases. This is usually the adolescent age group. I'll focus only on two series, which are the largest series in this. This was the first series published from Pediatric PSC Consortium, in which their median time from PSC recurrence after transplant was roughly around 2 years, and 5-year probability of recurrent PSC was roughly around 23%. That matches between 10 to 50% that is there. And the most common risk factor that they could find is presence of overlap with autoimmune hepatitis or overlap syndrome or autoimmune sclerosing cholangitis, whatever you want to call it, or younger age at the time of transplant. That is the more severe the disease is. That is what they could find on their multivariate analysis, that PSC AIH overlap was found as the independent risk factor for this. So this is the latest study that has been published last year. This is the largest data collection of recurrent PSC. The overall incidence was roughly around 27% at 5 years. And if you look at this series, the incidence, if you try and keep on following up these patients, the overall incidence keeps on increasing. So at 2 years is around 10%, 5 years is 27%, at 10 years almost half of them would develop PSC in overall allograft survival is poorer if you develop recurrent PSC. Event-free survival also goes down as the age or the follow-up after transplant increases, and also the survival with transplant liver goes on decreasing. So recurrent PSC has a bad outcome on the overall graft and patient survival. As I've already mentioned, younger age of the transplant, presence of IBD, shorter interval between diagnosis and liver transplant, showing the more severe the disease is. These were found to be risk factors for development of recurrent PSC. Also, multiple episodes of acute rejection, but viral application, other pre-LT factors, immunosuppression were not found to be significant factors. So if I try to compile all the literature on pediatric PSC for risk factors, you can find that inflammatory phenotype like presence of IBD, overlap syndrome, recurrent episodes of acute rejection, the younger age at the transplant, overlap, these are the most common risk factors. In our patient, he had developed de novo IBD. He had multiple episodes of acute cellular rejection before he subsequently presented with recurrent PSC. So how do you diagnose them? These were the criteria that were given in 1999. Somewhat they have been modified. So the criteria include that at least 6 months after transplant, you need to have a cholestatic biochemical profile, including higher GGT. Cholangiography should show typical evidence of sclerosing cholangitis, and you should always exclude other post-transplant complications like anastomotic biliary stricture, hepatic artery thrombosis, and chronic ductopenic rejection. Management, there is, as for PSC, there is no proven medical therapy for recurrent PSC also. UDCA has not been proven to be of any benefit. Symptomatic management should be done, and surveillance screening for cholangiocarcinoma should be done. One more thing, one more aspect is that everything boils down to gut now. So what happens is there is a gut hypothesis that if you have antigens which are being processed by the dendritic cells in the intestinal epithelial cells, they would take up these antigens, present them to the naive T cells, and there is something known as gut tropism. These T cells may subsequently express these chemokine receptors like CCL25 and MADCAM1, and they will again go back to form intraepithelial lymphocytes in the gut. But what happens in PSC is that rather than going into the intestinal epithelial cells to form intestinal epithelial cells, because of this increased expression of VAP1 in the hepatic sinusoids, these gut tropic cells then subsequently can move on into the circulation through enterohepatic lymphocyte recirculation. They can go into the hepatic sinusoids because there is increased expression of the same chemokine receptors that were there in the gut, CCL25 and MADCAM1, and they can subsequently lead to increased inflammation. So any alteration in enteric flora, because there is a translocation of these intestinal components and VAP1 substrates, because of defects in the pathogen recognition receptors, there is always a dysregulated immune response. They will go to the hepatic sinusoids, allow more inflammatory cells to go down into the hepatic sinusoids, lead to further cytokine cascade, which can lead to further damage. So this is one of the pathways for PSC that has been explained using the gut. So why it is important? Because some studies have shown that you can treat this recurrent PSC successfully using oral vancomycin. It has been used in non-transplant PSC patients also, but these studies have shown that vancomycin may be very helpful. They have shown complete resolution of portal inflammation and fibrosis on long-term follow-up also. The follow-up has ranged about 2 to 5 years of age in multiple case reports. Another case report that was published, they had recurrent PSC, vancomycin was enhanced, and almost 2 years follow-up, everything, and biochemically and histologically everything improved. And they have, some studies have shown that what it does is vancomycin, if you use vancomycin, it induces the production of T regulatory cells using TGF beta, and it has shown that multiple T regulatory phenotypes like CD4, CD25 high, CD127 low, or CD4 plus FOXP3, these oral vancomycin, it upregulates these T regulatory cells and therefore prevents hepatic inflammation. And also they have shown that once you stop oral vancomycin, these T regulatory cells go down, and once you reintroduce them, these T regulatory cells go up. But studies have shown that not even vancomycin or UDCA has been proven to be of any benefit in PSC patients per se. So whether it works in recurrent PSC after transplant is still questionable. So we already mentioned that IBD has a very significant association with PSC, that it is a risk factor for PSC. One of the studies that was published almost 10 years back had shown that patients who had undergone colectomy prior to or at the time of transplant, they were protective against recurrence. So whether colectomy can be indicated in all PSC patients pre or at the time of LT, it's controversial. It is very difficult. They may not tolerate this kind of major surgery, and there is high risk of pouchitis, even neoplasia in the ileal pouch that you make. Second component is recurrent AIH. Overall incidence in adults roughly varied around 20 to 30%. The same incidence is there in children also. Other than this study, 83%, it was published almost 20 years back. Latest studies have shown that around 30 to 35% is the overall incidence of autoimmune hepatitis. And the incidence goes on increasing as the follow-up increases. It is a very morbid disease because there is almost, this was a split database study. There was also all the causes of graft loss, 20% were because of AIH recurrence. This was the largest study on adults that has been published this year. This was the International Autoimmune Hepatitis Group. They had almost 736 patients. Overall incidence was 30% after 10 years. And they found that more severe the disease is, that is the younger the age of time of diagnosis and transplant, use of mycophenolate mofetil, sex mismatch, and higher IgG before transplant were found to be significant risk factors. And AIH recurrence has a negative effect on graft survival and overall patient survival, as you can see from these Kaplan-Meier survival curves. In pediatric AIH, type 2 autoimmune hepatitis, use of cyclosporin, avoidance or stoppage of maintenance steroids, some of the risk factors have been found to be significant. Early steroid weaning, HLA DR3, D4, increased severity of necroinflammatory activity have been found to be risk factors for recurrent AIH. AIH ALF has been found to be a protective risk factor, but these are only isolated case series. No definite recommendations can be made. But one important thing is that some studies have shown that histological recurrence precedes recurrent AIH. So they have recommended that every patient of AIH who undergoes a liver transplant should ideally be undergoing protocol liver biopsy, as it was done in this study. They did it at 1, 2, 5, and 10 years of age, and they could find that half of those patients, they could find these recurrence of autoimmune hepatitis based on high IgG and autoimmune markers based on protocol biopsy when their liver function tests were absolutely normal. So they recommended that, especially in this age group, this etiological group, we should definitely ask them to undergo surveillance biopsy after transplant to pick up these cases earlier. Whether steroids should be continued lifelong for AIH, grade of evidence is low. Multiple studies have shown that there was no correlation with steroid weaning, and there was no difference whether we would continue low dose of steroids in these patients. But majority of the centers still try and continue low dose of steroids in AIH patients. How do you diagnose and manage? Is same as autoimmune hepatitis per se. Because it is a morbid disease, there is a very high risk of retransplantation amounting up to 50% if they are left untreated. There is also a high risk of recurrent AIH in the retransplanted liver. But since these cases, if you are picking them early, especially if you are doing protocol or surveillance biopsy, you can always diagnose and treat them using the standard criteria that are used for naive autoimmune hepatitis only. The third and the last component that is very specific for pediatric population is the recurrent PFIC-like disease, especially PFIC type 2 or BSEP deficiency, that is the ABCB11 deficiency. We all know that BSEP is nothing but it is a transporter for bile salts or bile acids. It takes up the bile acid ABCB11 and it turns out from the hepatocyte to the canalicular space, throws out these bile acids from the hepatocyte to the canalicular space. Some studies have shown that it can recur. The exact incidence though is not known, but mostly the range of after transplant, it varies from 4 months to 17 years. But most common series have shown that within couple of years after transplant, you can have a recurrence of the cholestasis after transplant. They can be triggered by acute rejections, EBV infection, decreased immunosuppression of staph or steroids, but these are those from individual case reports only. And there is very high morbidity and mortality, and they can be fatal in almost 1/3 if you're not treating them properly. What actually happens is that there is actually a loss of tolerance. So what it means is that in those patients who have severe mutations would mean splice site mutations or stop codons mutation, premature stop codon. That means that if these mutations are acting, there is almost absent BSEP protein in the native liver. So they have not been exposed to this antigen since they were born. So once you give them a liver which has a BSEP in it, and you have a trigger like acute rejection, and this BSEP protein gets exposed to the immune system, the immune system start acting against this BSEP protein, and it is known as the autoimmune BSEP disease. And this usually happens in patients who have almost absent BSEP protein. Some studies, this was the first study that was published 2009, in which they documented in a 12-year-old child a recurrence of PFIC. She underwent 3 liver transplants simultaneously, back to back. First transplant had a recurrence, then again second transplant, then third transplant, had a recurrence in the third retransplanted liver also. And this was the first study in which they documented that there is presence of IgG antibodies. This is the canaliculi with MRP2 co-localization, and also they could document that in the liver biopsy as well as in the serums that they could document BSEP antibodies co-localization. And this is that you could find on chromatography also. You can see that they could find this BSEP antibody which was attached to this yellow fluorescent protein, and they could document the exact nature of these BSEP antibodies. Multiple studies have subsequently confirmed these findings, in which they could document BSEP antibodies in the biopsy, and also could document in all these 7 patients, they could find that BSEP antibodies were strongly positive in these patients. So how do you approach such case? If you have a PFIC2 patient, look at the mutation. If it is severe, suspect that they may, if they develop cholestasis in the future, they may have an autoimmune BSEP deficiency. Watch for cholestatic symptoms. The good thing about this cholestasis is to differentiate between acute and chronic rejection, the GGTP continues to be low. If you look at all rejection cases, majority of them would have a higher GGT, but in this case, the GGT continues to be low. Even if they develop jaundice, they may develop pruritus, they may develop high serum bile acids. So if you have these cases, confirm that there is presence of canalicular antibodies using MRP2 and anti-IgG, antibody against the human IgG. Step 2 is to confirm whether these antibodies are anti-BSEP antibodies using the fluorescent proteins you can use, and you can confirm it using the chromatography also. Step 3 is confirm the antibody titers because it has a prognostic value. If it is not there, you should look for other DDs. The most common DD for cholestatic symptoms are biliary abnormalities or chronic rejection. The only treatment options that are there it's like an autoimmune disorder. So you have to increase your immunosuppression. If it does not work, go ahead with physical removal of antibodies using plasmapheresis or immunoadsorption. Third step, if it does not work, use rituximab, anti-CD20 antibody. And the last resort is liver transplant. Multiple such patients have undergone 1, 2, 3, 4, 5 liver retransplants. There have been case reports like that also. But it continues to recur in the transplanted liver. And this was a study that was published 3 years back, the only case report of rescue stem cell transplant after 3 liver transplants. So what they actually did is from the mother, the child was transplanted, and they could document the decrease in the antibodies. As you can see, this is the pre-BMT, 6 months post-BMT, 12 months post-BMT. The overall titers have decreased. Even in the serum, you can see the titers have gradually come down. And this in the serum also, in the biopsy also, you can see the overall decrease in the titers of antibody. It takes time. In the serum, it clears more early, and the canaliculi, it takes time. Thank you so much, and I'll be happy to take any questions.